Thanks, Arthur. It's great to be back here, and I'm going to sort of talk about something that I'm really passionate about, and really lucky to have Dr. Kuhn here, who's really like the modern father of this therapy. Oh, this goes fast. These are my disclosures. So I think for the next 20, 30 minutes, Arthur and I are going to talk about these no option patients, and I think it's a little confusing because I think no option means a lot of different things to a lot of different people. As a vascular specialist, when I think about a no option patient, I used to only think about what these patients looked like angiographically. I'd see an angiogram, I'd see a foot that had no named blood vessels below the ankle. And that certainly can describe an anatomic contribution to somebody who's no option. But there are also physiologic components as well as technical components that can go on to contribute to making patients no option. When we look at this subset of patients, I think that it's really hard to wrap your head around which patients are no option from a population-based standpoint, but this is a really interesting paper that looked at the number of amputations that were done in the US in 2017, and it followed patients 1 year before their amputation and 1 year after their amputation. And using Medicare data, these patients all had to have critical limb-threatening ischemia diagnoses and then subsequently went on to major amputation. And what's really compelling about this is that when we look at America in 2017, 92% of patients that got an amputation did not get revascularized. They didn't even get an angiogram, right? So that's looking at patients who had low and medium intensity vascular care that ultimately went on to get amputation. So these patients may be the cohort of patients that could potentially benefit from DVA or TTT. So we all see this angiographically, and I think Dr. Finelli showed us pictures that look like this, and so did Dr. Kuhn. But these angiograms correspond with macroscopic images of the foot, right? So these angiograms could correspond with any type of presentation that you can see on this right-hand side. And sometimes these patients may not even have a wound, right? So it's very difficult to correlate, an examination of a patient's foot and what their angiogram is going to look like. So what do we do now? Because we know that diabetes and non-healing foot wounds is a tremendous burden on our domestic, healthcare system, and it's associated with an increased risk of mortality. And we know that patients who get diabetic foot ulcers are at a high rate of mortality and overall. So what about deep vein arterialization? So deep vein arterialization is a choice that we can utilize when conventional strategies are unsuccessful or you simply can't do them. These patients have no option. And what it is the creation of a fistula between a tibial artery, so an artery in the calf, and its corresponding vein. And it's generally done percutaneously, and it leverages a healthy venous system to deliver oxygenated blood to the foot. Now, there are a whole bunch of ways that you can do this. I think we alluded to Dr. Ferraresi multiple times this morning already, but he likes to describe the off-the-shelf or using non-purpose-built tools as the artisanal sort of strategy to do it, and that's probably the strategy that's been most performed internationally. Several years ago, the LymphFlow system was approved by the FDA, and now it's commercially available here in the United States. But even more so, the historical strategies that people utilize to deliver this type of therapy relied on open surgical techniques. And you can do that either using the deep or superficial venous system. So the seminal paper that here in the United States we utilize to sort of give insight into the outcomes for these patients is the PROMISE-2 study, which was published in the New England Journal of Medicine several years ago. And they enrolled 105 patients at 20 different sites in the US. And at 6 months, including patients who all had wounds and some of whom had previously undergone previous intervention, at 6 months, these patients had a 66% amputation-free survival and 76% rate of limb salvage, and half the patients had either healed or were in the process of healing. And we're talking about patients who would otherwise be looking at major amputation or palliative wound care. So I think that this provides sort of the light at the end of the tunnel for some of these patients. When we look at the types of patients, a lot of patients with diabetes, a lot of patients with hypertension, the comorbidities that can contribute to critical limb-threatening ischemia, but only 18% of the patients in this study had end-stage renal disease, which I feel isn't necessarily an accurate representation of the patients that I see and take care of in Texas. But again, all these patients had wounds, and some of these patients had Rutherford 6 disease. So Rutherford 6 disease is basically patients who either have a non-healing TMA or patients who would require a transmetatarsal amputation to ultimately have a salvaged foot. It's also nice to note that this procedure was done 99% of the time technically successful. So this is a relatively easy type of procedure to perform. None of the procedures utilized the anterior tibial artery, and the predominant blood vessel that was utilized to do this procedure was the posterior tibial artery. Limb salvage rates were 69% at 1 year. And the unique thing about this therapy is that, comparatively speaking, when we do a conventional revascularization, whether it's a bypass or you put in an SFA stent, right, we expect patients' symptoms to get better immediately. But after a deep vein arterialization, in this study, they demonstrated that the wounds actually got worse, and patients' pain scores didn't decrease immediately after the procedure. In fact, it took several months, 3 months, to start seeing an improvement in patients, the size of their wounds as well as their pain scores. But over time, when you look at these patients macroscopically over the course of a year, we see high rates of healing and wound healing. And nearly 50% of these patients at 1 year were completely healed. I'm going the wrong way. So that's fine and well, but I think it's very important to talk about what happens to these patients when they aren't afforded these advanced types of therapy. And the CLARITY study was a natural history study looking at patients who'd otherwise potentially benefit from DVA or limb flow. But instead of doing that procedure on these patients, the therapy was withheld. So this was just purely to see what would happen to these patients. And when we look at the outcomes of these patients who were that patient population that was included in the study was very similar to the patients included in the preceding limb flow studies. Over 12 months, you can see CLARITY being the natural history study and limb flow being the therapeutic study. On the bottom, the survival was worse, the limb salvage was worse, and the amputation-free survival was worse in patients who had this therapy withheld from them. So when I look at my own experience in conjunction with a group in Washington, D.C., we did 63 of these procedures. And these are real-world patients not included in the sort of PROMISE trial. So these are non-clinical trial patients. You can see the big differences between our experience and that of the clinical trials is that 35% of the patients that we did this procedure on had end-stage renal disease. That's almost 3 times the number of patients or the percentage of patients that had end-stage renal disease in the PROMISE trials. And then additionally, we included more patients with more advanced disease. And we're still following these patients out, but our 6 months results are very, very similar to the PROMISE 1 and PROMISE 2 results, with our amputation-free survival being 73% compared to 67%, our limb salvage rate being 74% to 76%, and our survival being 92.5% to 88%. And that's not necessarily, I'm not showing this to brag, I'm showing this to demonstrate that this therapy is reproducible in a non-clinical trial environment. When we look historically at the experiences, we can look at this meta-analysis, and this looked at basically almost 1,000 patients from more than 10 studies, and these studies were very heterogeneous. They were different techniques and different locations, and the follow-up was inconsistent, but basically 1 year we're looking at a limb salvage rate that's 75% and a survival rate that's almost 75%. And when we look at this study, there was no collective commentary on wound healing. So again, to reiterate that these experiences, single center, multi-center, prospective clinical trials have demonstrated that, this is very reproducible and we can expect these outcomes with this therapy. But despite that, this is a publication very recently looking at Medicare data in the U.S. of outcomes following deep vein arterialization based upon CPT code, and the results of this study were a little bit more jarring, with at 1 year limb salvage rates of only 53%, amputation-free survival of 33%, and survival of 65%. So worse than what we had presumed to expect after this therapy. And when we think about this, and I think about that data, I think about my experience doing this procedure over the course of the last, 5 years. There was a lot to learn. I think one of the commentaries I have of that last paper is that because there was so much to learn, I made some mistakes and I chose the wrong patients. That contributed to early outcome failures, whether that's amputation or mortality. And I think that Medicare subset of patients lends insight into the fact that you've new users using this therapy, and they had to learn some things the hard way as well. But ultimately, I hope you think that TADV, or deep vein arterialization, is a safe and feasible operation for a unique group of patients. It's certainly better than wound care. These patients would otherwise be destined for major amputation, and it's seemingly very reproducible, but there is a learning curve, and I think that it's the work of people in this room that will help us better understand what's going on with this from a technical standpoint and a physiologic standpoint. So ultimately, we can help more patients avoid major amputation. But I think Arthur's going to talk about how DVA doesn't always work, and there are more options. Thank you.